Now, if you've been to a webinar before, you'll remember that the I-STARR project is supported by a grant from the National Institute on Drug Abuse and is part of the larger NIH Helping to End Addiction Long-Term Initiative or HEAL initiative. It is also one of several projects that comprise the Consortium on Recovery Science, or the COARS network. Next slide, please. So I'm Carmen Masson. I'm a professor of psychiatry in the School of Medicine at the University of California, San Francisco. I co-lead the I-STARR project with Dr. Amy Miracle, who is a research scientist in the alcohol research group at the Public Health Institute. The team also includes co-investigators Sarah Zemor and Lenny Jason, biostatisticians Meena Subraman and Libo Lee, communications specialist Diane Schmidt, and Dustin Kegsville, and the team's project coordinator, Quinoja Capitini. Next slide, please. So the I-STARR project activities are guided by an amazing 17-member advisory board comprised of a diverse group of leaders from across the country. Our advisory board members represent recovery and recovery housing leaders, treatment providers and payers, national policy advocates, and researchers and educators. In fact, you will be hearing from one of our advisory board members today. Next slide, please. And with that, let me tell you about our presenter, Dr. Sharon Reif. Dr. Reif is a professor at Brandeis University's Heller School for Public Policy and Management and part of the leadership team for the Institute for Behavioral Health. She has over 25 years of experience conducting health services research related to substance use disorder, treatment system, and recovery supports, with a focus on access, quality, and delivery of services, as well as outcomes and recovery. She is the co-director of the NIDA-funded Brandeis Harvard I-STARR Center. She leads NIH-funded studies on systems approaches for treating opioid addiction, measuring recovery from substance use disorder, and pathways to alcohol recovery in the Black population of Detroit. Dr. Reif has studied medications for treating addiction, system approaches to improve treatment for substance use disorders, access to behavioral health services, the role of incentives in driving quality, and the intersection of alcohol and drug use or misuse with other disabilities, pain, and chronic conditions. She also has interest in addressing stigma and discrimination due to substance use disorder and disabilities. At the Heller School, Dr. Reif is part of the leadership team for the Institute for Behavioral Health, part of the Schneider's Institute's Health Policy and Research, and deputy director of its National Institute on Alcohol Abuse and Alcoholism doctoral training program. So without further delay, let's turn the presentation over to Dr. Reif to learn more about recovery housing's place in health services research. Next slide, please.
Great. Thank you so much, Carmen. And I appreciate you and the I-STARR community for inviting me to come here and talk about health services research. I'm an addiction health services researcher, and I will tell you what that means. So maybe more of you will become that as well. I do want to mention the I-STARR Center for a quick moment. I-STARR stands for Substance Use System Performance Improvement Research and Engagement. And we really look at how payment and delivery systems intersect and think about access to care, low barrier access, the role of Medicaid, the role of policy, the role of payment. And we'll be dropping that link in if you want to learn more about the I-STARR Center and join our mailing list as well. If you're inspired by health services, it's a great place to learn more. Oops, did you not hear anything I just said? You did. Okay, so I must have clicked audio by mistake. I'm sorry. Next slide, please. Thank you. So today I will do a little bit, actually a fair amount about what is health services research? What do we mean by this? And how do we then translate it into the addiction field? And that's treatment and recovery and beyond, broader than that as well. What are some key issues as we think about applying health services research to both addiction and to recovery housing specifically, and how could we use health services research to advance the recovery housing field. And then, as I-STARR usually does, we have plenty of time for discussion at the end. Next, please. Next, please. Thanks. So what's the definition of health services research? This is another place. Academy Health is the professional organization for health services researchers that is not just about addiction. There's also the Addiction Health Services Research Conference. If you don't go to that and you are interested, it's actually on pause for this year, but we'll be back in 26. But Academy Health defines health services research as a multidisciplinary field of inquiry, and this multidisciplinary piece is important. So we're coming at it from many perspectives. So I am trained as a health services researcher, but my training was interdisciplinary. I learned about sociology, about economics, about political science. We bring in people who have clinical backgrounds. We bring in health economists. We bring in policymakers. We bring in other kinds of roles and training. So we're taking a broad perspective of what are the research questions that I'll be talking about as we go on. It can be both basic and applied. It can be about designing interventions, understanding an intervention at its basic level, but also what happens out in the real world where things are happening and we want to understand what's happening and why. So health services research examines access, the use, costs, quality, delivery, organization, financing, and outcomes of healthcare services. That's a lot of stuff, and I'll unpack it a little bit more as we go. And the goal is to produce new knowledge about the structure, the processes, and the effects of health services for individual people and for populations. And so this is really about how do we understand what's here in the real world? How do we understand the whole package? Often when we do research, we talk about, okay, what happens when this person gets this intervention? Maybe it's a vaccine, or maybe it's a clinical care. And that's all we want to know, what happens to that person. Health services has taken a bunch of steps back and above and looking more broadly. Plainly here from Academy Health, the health services research asks the question, what works, for whom, in what context, and at what cost? Next slide, please. And our friends to the north in Canada had a very nice infographic, and so I borrowed this from them. But really, it comes down to we're asking those questions, but the goal is to enhance quality for patients. We want patients to get the care they need. And I'm using the patient level language here. We'll get to clients or residents as we move closer to addiction and recovery housing, but also to improve the healthcare experience for the providers, for the system of care. We need efficiency, we need effectiveness, we need everybody to be happy and engaged to work to the same goals. But we also have to understand, particularly in the United States, that we have cost issues. And the way that our system is built, it's not just one system, it's many systems. So how do we do this in efficient ways where we reduce costs, but we're also maximizing value of care? And ultimately, the goal is to improve population health, not just individual health, although that's the most important part to build up population health. Next slide, please. This is a great article that I came across as preparing for this by Sandra Galea and I think it's Catherine Entman, talking about how health services research really goes beyond the classic at this point in time. We all know that intersecting identities are important and that we're heterogeneous, and that's really important to understand, that it's easy to talk about population health, but we know that everybody in a population does not experience health in the same ways, and they don't experience health care in the same ways. And so while we might be building systems of care, we might be building population health, we have to understand what happens at those lower levels of individuals as well. And similarly, we need to integrate social and structural contexts. The picture that's very hard to see is sort of a social determinants of health picture. Often we think about things like education and housing and healthcare literacy, access to healthcare, but it may also be about the neighborhoods that we live in and where the healthcare is located relative to where we live. It may be about growing up in poverty or growing up with many opportunities available to you. Those social and structural contexts matter for health and need to matter for health services research as we're asking questions about how to improve population health. And then, of course, a life course perspective. What happens for younger people is not the same as middle age and older people, and keeping that in mind as well. Next slide, please. So you might also be wondering, where does health services research fit. I mean, it's easy to say, I know what research is. Often we think in the middle right there, basic research, right? Somebody sitting in a lab, they're developing a new medication or they're doing something like that. That's basic research. We have to have that. We have to understand what causes alcohol use problems. We have to understand genes. We have to understand all sorts of stuff. And then we get to sort of preclinical where those things are being tested, maybe in animal models or maybe in early human models. Also very important. We then get to clinical research. So you go and you see your doctor and they say, all right, well, here's a medication in this clinical trial, or here's a type of chemotherapy, or here's a type of behavioral intervention. But you might get the other one that we usually use as well. And that's also important. So all of these are needed. Then we get to clinical implementation. Here's an evidence-based practice. We're pretty certain that it works. We're going to throw it into the VA and have all the VA hospitals use this clinical practice. And now what? Now we need to see, does it actually work in the new system that we put it into? Maybe it's not the VA. Maybe it's a small residential program. Maybe it's something else like that. What happens when you put it in? Because when we do clinical research, it's often very bounded. It's very specific. You must do this service in this way, and you must examine them 6 weeks later, and you must test these 3 outcomes. And we know, going back to that slide about how heterogeneous we all are, also where we get care, what the systems are, all of those things have a lot of variety. And that's where at that public health top, that's where part at the top, that's where health services research comes in. Because we need to understand what happens out in the messy real world with messy patients and messy staff and all those things that everybody may have best intentions, but it's rare we're just one piece. Somebody said it, I was just in a lecture before I came here, somebody said, they were talking about somebody who had a chronic serious disease and serious mental illness. And the quote was, I'm not a piece of cake. You can't take me apart. Or maybe I am a piece of cake, but you can't take me apart and say, here's your serious mental illness part, and here's your chronic disease part. We have those things fit together. And so again, we need to understand all of these interventions that we put into place in the context of the real world, and then taking that further step to look at costs, to look at staffing, to look at all the things we need to make it work the way that we hoped it would work, and or to refine it for this system, for these types of patients, and so on. Next slide, please. And this is just, you don't need to memorize this. This is very economic, but it's one of the models that we've used in the Spire Center. My colleagues, Dominic Hodgkin and Connie Horgan and others, had put this together to really think about where are there lever points that people who are doing this kind of work about health systems could be examining research questions. And when we think about a health system, we have the patient on the bottom left who interacts bidirectionally with the clinician. But the clinician is also interacting bidirectionally with who pays for them, their provider organization, their employer. And that organization is interacting with the payer, often the insurance company, could be Medicaid, could be private, could be something else. And the payer defines what the patient is entitled to. So while we may say, okay, you have problem X and you need service Y, we have all these other things that are happening at the same time that help define whether you get that service. And we as health services researchers could be looking at those things. So for example, this slide came out of a whole bunch of studies around health insurance. How does health insurance define what kind of access to care people with mental health and substance use have? And there are all these points in which they may define that. If you look at your health insurance policy, you see that you might not have access to residential care for substance use disorder. That's very common. That is an insurance decision. That's a payer decision that affects the patient directly. But they may also say, well, we're only going to pay the clinician $15 an hour for every client that they see. And that affects the patient also, because now maybe the clinician's going to say, I'm not doing that. That's not enough for me to be doing that. How do we interact? How do we understand the implications of those kinds of decisions? Okay, next slide, please. And I'll talk for a moment, you can move to the next slide. I'll talk for a moment about data sources and methods, because this is where it does get a little complicated. And as you start thinking about what kinds of research questions you might come up with as I'm going through and as you're thinking about this, this matters. So as I've been talking about, health services research applies at these many layers, right? We've got the person at the center, and you'll see, those of you who know your theory, that this relates to ecological systems theory, but a person is set within, in healthcare, within a workforce that's engaging with them, organizations that's employing the workforce so that you seek care from, but also within your own community and culture and that of the organization. Those may not be the same thing, mind you. And then society and policy. What kind of policies do we put in place, such as to encourage medications for addiction treatment? Or what kind of policies do we put in place that might discourage somebody from seeking care because they might be at risk for other things? And those are the kinds of things that we need to pay attention to in what's sometimes called the outer context of health services research, where we might not be able to change that, but we can understand it, and we can see how it influences the questions we have. Next slide, please. So if we get more specific about this, how do we collect the kinds of data we need? So health services researchers often use surveys and interviews. Some of that's going to be population surveys, like the National Survey on Drug Use and Health, or other kinds of information that we get about people who have healthcare problems, substance use problems. We might do surveys or interviews with organizations. This might include hospital systems or substance use treatment systems. It might include specific programs or systems of care. If you have a system that has a continuum of care for addiction treatment or addiction and mental health treatment, for instance. Interviews and focus groups, getting qualitative data from patients, providers, policymakers, other stakeholders to understand how they're thinking about the healthcare needs and the healthcare solutions. We use a lot of existing data. I'm a quantitative researcher. This is really where most of my work is. So if we look at claims data from health insurance, we can understand, what do people actually get? So I can see, if you are enrolled in Medicaid, I can see, do you get how many outpatient services? Is residential covered by anybody? A good example for this is screening and brief intervention. Screening and brief intervention used to not be covered because there was no code. There was no procedure code that you could put into the claims to make it billable. Once they made it billable, it's still not very covered. So we can see that. And that says to us, well, are we not seeing that in the data because it's not being offered, or because it's not being charged? How do we improve this to get more screening and brief intervention done? That's a kind of example of where claims can matter. Administrative data, this could be from your state substance use agency, for instance, where you have the admission and discharge records. Could be things like death records from the state or from the county, depending where you live. Electronic health records or other medical records. That gives you much more depth of information, much more nuanced information. If you're using claims, all we can see is you got a service. But as we all know, one outpatient service may not be the same as another outpatient service. There's no way for us to understand why you were referred to that service, who you saw. Well, we can see who you saw, but we can't see what happened in that service. Administrative data will help that. Interviews and focus groups will help that. Public health surveillance data. So your departments of health, for instance, capture data. This is useful particularly for overdoses, for example, because those are collected at the public health level. And then there are many other ways that are being developed. There are plenty of apps these days and digital tools that might be collecting data that could be used to answer some of these questions. Next slide, please. And then we try to use rigorous statistical methods, and we can do that particularly when we have large data sets that let us create control groups, even though we're not doing prospective trials. I'm not going to go into details on all of these things. So I just wanted to mention them. Implementation. What happens when something is put into place? I'm doing a study right now where it turns out the implementation, we're not finding the results we hope to find, probably because it wasn't implemented in a way that was going to lead to those results. This is very common in health services research. And these kinds of studies could be both qualitative and quantitative. Performance metrics, understanding what the outcomes are, what are the processes, how do we track those things? So I know program A versus program B, they may have different ways they're doing it, but I can understand in both of those how many people stay on medications for opioid use disorder for at least 6 months, for instance. That's a performance metric. That gives us something to aim for and to tweak what we're doing to understand how to improve it. And then, of course, understanding the literature, understanding the policies that are out there, and then for the economist types, really getting to cost effectiveness and cost benefit and understanding what it means to implement one of these new interventions. Next slide, please. And you can go on. Thank you. So bringing this closer to addiction, I've been throwing out a couple addiction examples, but I want to talk about it a little bit more. So as I've been talking, health services is about systems of care. I think that's really important for us to understand. It's not only, but if you want to get to populations, you really need to be looking at systems and understanding how they work together. And I think that we've had a lot of progress in the last few decades about understanding how alcohol and drug use disorders function, how people with alcohol and drug use disorders present in systems of care, and that they shouldn't be treated in isolated ways. And this includes, in fact, from mental health, which for a long time was also siloed. So if we use health services research to study addiction treatment and recovery services, recognizing their complex needs, we can then talk about the context of other substance use and misuse. So for instance, sometimes we want to look at alcohol, but you can't only look at alcohol for most people because many people are using multiple substances. Health and mental health issues, as we've been talking about, some of those may be related to the substance use and some of them may be independent from the substance use, but you can't pull those apart. Other biopsychosocial factors, the systems of care that exist, and of course the policy environment. And if we do this, then we can focus on an interconnectedness that really focuses on the whole person and how do we do this to help that person in prevention, treatment, delivery, recovery services, and so on, again, with a focus on organization, management, and financing. Next slide, please. So we can assume, we do assume, um, that these services can be effective. We often know that they're not always effective. We know that outcomes are not 100%. They're not 100% for anything in medical care. So addiction care is not much worse than a lot of other things that are in healthcare. But we have to make that assumption, because if we make that assumption, then we can talk about, well, they're effective if people can get care. That's a big barrier that we have in addiction, is getting people to care. Some of that is intrinsic and some of that is about context. The care that they're getting is optimal, that we're actually getting evidence-based care, that we're getting things that matter, and equitable, that everybody is able to access the same kind of care that they need. That people use the amount and type of services. Getting somebody into the door is important, but it's not enough. You have to get them engaged in a way that is going to help get them out of the door in a manner that is successful. That the services provided are cost effective and current clinical best practices and quality guidelines are adhered to. And then the same kind of finding we have here, access, utilization, et cetera, et cetera. Next slide, please. So the goals of addiction health service research are to identify ways to organize, manage, finance high quality care, to improve systems of prevention, treatment, recovery, enhance quality, reduce adverse consequences, and examine how social factors, financing systems, service environments, organizational structures and processes, and you'll note in this definition, it's not specific to addiction, but brings in health technologies and personal beliefs and behaviors, because those are also things that are important for each of these issues around access, utilization, et cetera. Next slide, please. And thank you to Amy, who had developed some of this set of questions here about, it's not just that we have addiction and addiction is different. Addiction services are different because of the way that the field has developed. We are in a variety of settings and sectors. It's not all medical, for instance. We have practitioners who have different educational backgrounds and training. Some of that is formal, social workers versus psychiatrists. But some of it's informal, where we have people who are licensed drug and alcohol counselors. We have people who are peers. That all challenges the way that we assess a system of care. Certifications, licensure vary, and some people don't have any of the above. We have the issue of non-voluntary treatment. That is important to understand when we're assessing why a person is having the outcomes that they're having. Many of the behavioral interventions are outside the medical setting. We have a disproportionate role of publicly supported services. Part of this is Medicaid, part of this is also traditionally block grants to the states and funding people that way, and also a lot of out-of-pocket care for the services that aren't paid for, such as residential treatment, or in some cases, some of the medications that people use for opioid use disorder. I mentioned the peer support workforce, but also we don't have a solid outcome. Our outcome is so often about substance use. Did you stop drinking? Well, stopping drinking and being in recovery is not the same thing. And so we're really, I think the recovery field and the group that Carmen mentioned in the introduction are really starting to work on this. And it's very, very important for us to get to, but it remains a big challenge as we are advocating for better addiction healthcare. Next slide, please. And just to comment that we can do health services research at all phases of addiction-related work. We can do it looking at prevention, recognition, which would be screening, assessment, treatment, and maintenance, which includes getting to recovery. Next slide, please. And so we have some topics that people are talking a lot about in addiction health services research. Medications, which I'll come back to in one of my examples. Integrated care, this is very important. Getting mainstream medical treatment where people are seeking services often and may not even be talking about the addiction issues. Integrated with addiction. So we're getting people where they're at, which is often in a medical system, and we're engaging with them and we're referring them to specialty if they need it. But also if they're walking into specialty, we're helping engage with those other things. Making sure that we're engaging with vulnerable and marginalized populations and providing culturally appropriate care. Recovery coaches, peer workforce, the recovery residences, housing, social determinants, racial equity issues that which are known but haven't been examined very deeply still. Expanding the addiction workforce. We have a lot of challenges there, and some of that is about how we finance care. It's not all about addiction workforce itself. We know it's a very dedicated group of people. Access to recovery support services, and I'll add payment for recovery support services. When you're done with treatment, if we're in a medical model, which most of us are still functioning in, but when you're done with treatment, who's going to pay for that then? Where does that come from? Because your insurance isn't going to pay for it. And so building that in, that's an important question. Low barrier access to care. Next slide, please. And so we can play these out into specific kinds of questions. And these are some examples. How do we enhance service engagement and retention and reduce stigma-related barriers? An example about telemedicine, which really grew tremendously during the pandemic. How is it implemented, financed, and sustained? Was it just, okay, it was the pandemic and now we're back to in-person care, so telemedicine doesn't matter? Well, we know it matters a lot for certain populations and certain geographic areas in particular. What workforce-related factors are most relevant? Workforce is a really huge question for access, implementation, sustainability of evidence-based treatments. What kind of geographic differences in substance use related policies impact how people get services? Can we improve how large systems of care adopt evidence-based interventions? Large systems don't move very nimbly, and it's very hard to get them to adopt evidence-based interventions. How do we get those to happen? And what's needed to maximize the efficient delivery of high quality and personalized addiction treatment and related services? We also don't do very much person-centered care. We talk about it, but that's not the way the system is designed. You walk in and you get what you get. And then if you don't do well, it's often put on that person as they were the problem and not the system was the problem. Those are the kinds of questions we can do in addiction health services. Next slide, please. So I'm going to give 2 examples just to get more close to the I-STARR focus. I'll talk about medication, treatment, and recovery housing. And then we'll have plenty of time for discussion and for any questions that you all come up with. So example number 1 is looking at medications for addiction treatment. And I know I-STARR is mostly focused on MOUD. And you can go to the next slide, please. And we know that medications for opioid use disorder are really considered a cornerstone of treatment, that you essentially must have access to those for people to be able to do well. And that has been shown in study after study, and they work better than other types of care. It's not to say that they shouldn't be done in conjunction with other types of care, but that's absolutely the way that certainly the clinical field and the services field see that it should be, but it's not the way that it's demonstrated out in the real world. For AUD, the medications are important, but they're less life-saving. And so sometimes when you talk to people, they distinguish between these two types of medication because reducing craving and high intensity drinking are important, but they're not the same as saving your life in a literal, you're not going to overdose and you're not going to die in the next day. And so that's an important distinction that some folks make. I believe that both of them are really key for the toolbox. And I just list here the couple medications that have been FDA approved. There are others that are being used that are off-label, such as topiramate, sometimes gabapentin, and there's a lot of talk now about the GLP-1s like Ozempic and how they may be affecting alcohol in particular. So next slide, please. And despite this importance of having these medications and anywhere else in clinical care, medications would be a perfect assumption. You have a problem, we have a medication solution, we should offer you the medication. If you don't want to take it, we'll talk about what the alternatives are. But this is the way that we function, and that's not true still in substance use care. Buprenorphine's been around for more than 20 years, and we're still talking about how important it is or how not important it is. But there are many, many reasons why people are not using these medications. Some of those are systemic and clinical factors. There's a lot of stigma. I don't want those patients in my practice. I don't treat those patients. Why should we have to learn this thing? They're going to mess things up. And I don't mean to be making anybody feel bad who's on the call, but we know that this is the kind of messaging that we hear when people have done qualitative studies. And it's also things like prior authorization, or your insurance covers one medication and not the other medication. And so then you have to choose, well, buprenorphine works better for me, but I can only get methadone, and methadone I have to go to every day and drive for an hour to get to, or take a lot of public transportation. So there are structural barriers there. Clinicians often don't have training. They don't have training about substance use issues. They don't have training about medications. And even if they do get training, that may be very brief. And so they may not feel that they have enough knowledge, skill, cognitive capacity, as you see on the right side under clinical factors. Systems may feel like they don't have the capacity to add one more thing. This is true. Doctors may feel like they don't have the capacity to add one more thing. Lack of institutional support, costs, reimbursement, the environment, who are the providers, where are they located? And then patient factors. Patients have their own stigma about these medications. And that's also important for us to understand. How do we increase their knowledge about the medications? It might also be their families or people close to them. Same issues about insurance coverage, access to care, and the need or not for supportive services that go along with that. Next slide, please. So the kinds of questions that we have, and these are ongoing and can be adapted for other settings. What are low barrier models that enhance access to medications? Emergency room induction for buprenorphine is an example of that. What are they? How do they work? How can they be sustained? What are the staffing needed? How do we pay for them? Are there policy or other facilitators to encourage prescribing within a system, within a certain type of provider? Can medical assistants and nurses effectively be used as prescribers? In some places they may prescribe. How is that working? Is that better? What types of training or knowledge translation models improve provider comfort with prescribing? So there are things like consultant models that come through. So you can call up and talk to another provider when you have somebody in front of you who's saying, this isn't working for me, what do I do? And you, the provider who may not be as experienced, can talk to somebody else. How do we effectively reduce stigma? And what kind of partnership models would allow non-medical facilities to facilitate use of MOUD, MAUD? And that is the idea of what kinds of mutual agreements do you need in order to have somebody else? Maybe you send a client over to another provider to get inducted on the medications, but then you work with them even though they're taking the medications. That's the kind of thing. The question that just dropped in the chat, can pharmacists be used to expand access to prescribing? There is a lot of work being done in that area, and it's a great example of a health services research question, because it brings in the policy issues, it brings in scope of practice issues, it brings in stigma, it brings in costs. There are a lot of people who think that the pharmacist is really a great place for expansion because they're already engaged in the whole person. They're already engaged with medication. On the other hand, there's also a lot of, we don't want those people in here, issues with pharmacists and issues around confidentiality and other kinds of things that come up. Our team was just involved in, Amy, I don't know, you could do a quick search if you find it, on our OPRC website, with a study funded by the Pew Charitable Trust to look at the business case for methadone prescribing in pharmacies. So I think that, thank you for sharing that question. Next slide, please. Okay, so getting to our primary topic for I-STARR, which is about recovery housing. And you could go to the next slide, please. So we know that recovery is not just, as I said, about stopping substance use, but it's really, and this is an NIAAA definition, really about fulfilling basic needs, enhancing social support, spirituality, if that's important to you, improvements in physical and mental health, quality of life, and other dimensions of well-being. This is part of why it's hard to measure it. These are all things that what it looks like for me is going to be different than what it looks like for you, for somebody else that you're close to, etc. But this is recovery as a whole being. It's not about one little aspect of it. And so then, of course, we have recovery support services to move us towards each of those things, to get us closer to getting to health and well-being, and not about misuse of alcohol and drugs. Next slide, please. And so there are many types of recovery support services. You all are probably actively involved with many of these. They range from some of the formal stuff about mutual help and peer support, recovery coaches, to even system-wide things such as recovery-oriented systems of care, where you get many kinds of aspects of a community involved. But you also see down at the bottom, I include integrated care, where I was talking about that earlier as a general health services question. Chronic care management and care coordination. How do we make sure that somebody who walks in the door of a substance use facility is getting their bipolar disorder taken care of, is getting their dental needs taken care of, is getting other things that have been put off while they've been actively using substances. And trying to really focus on patient-centered care and shared decision-making. If we want to get somebody to recovery, they need to be helping define what that means. Next slide, please. So I borrowed the NAR version of types of recovery resident support because we know that what recovery housing looks like varies within this type. Some are fully peer run, some are managed, some are much more clinical, but also that they sit within all of these other kinds of care that I've been talking about. On the right-hand side, these are other kinds of care that are about substance use. You may end up in a recovery residence as the first stop, right? Maybe you've gone through a withdrawal management program, and then you go to a clinically oriented recovery residence. But maybe you end up in recovery residence as a peer-run housing while you're doing outpatient care, and that's the way that your pathway goes. Mutual health groups are often engaged either at the house or encouraged outside of the house. But then we also have these needs, medical care we've talked about. But if we want to get to that whole person recovery, we might also need social services. We might need legal services. We might need mental health services. And I'm sure there's a whole bunch of circles that I forgot here. So when we think about what happens in recovery housing and where our health services questions are, we need to also pay attention to these linkages with this other piece. Because much the way I'm saying you have to look at the whole person, if you look at only one setting in which the person engages, you may be missing the essential elements to get somebody to recovery and help them sustain that recovery. Next slide, please. And I've been using a recovery capital framework. This is an older version of it. I know there are many different ways people talk about it, but also trying to get to these issues of how do we build social capital? How do we build friendships? What kind of resources? What kind of physical capital? Do we help people get employed? Human capital, do we help with education or knowledge for doing certain kinds of things? And cultural capital, how do we strengthen the cultural experiences that people have and bring as who they are as part of a strength for being in recovery. The reason I bring this up as a framework is this is the kind of thing, if you have this kind of framework or another framework that you like better, that can help define what are the questions we're asking. If we really care about why are so many people who have substance use issues or in recovery housing unemployed, and how do we change that? We have to understand, well, what does it matter? And how do we change that? And now how can we look at the questions around employment among people with substance use issues, even in recovery, and how unemployment is a barrier to maintaining recovery, right? So we need to pay attention to those things. Next slide, please. So I came up with a list of recovery housing questions. These are, again, pretty high level, and you may have your own recovery housing questions. Again, these are questions like effective models across geography, populations, and needs. I know that I-STARR has focused some on recovery housing for people with criminal legal histories. We might have recovery housing for women with children. We might have recovery housing in rural areas or small towns versus big cities. The effective models for each of those may matter. We know there are a lot of barriers in new locations, not in my backyard, other kinds of things that happen. Who is the recovery housing workforce? I think this is really, really important because a lot of it has grown up from the peer support, mutual help way of being. But in some cases, they're a very formalized workforce. How are they paid? How are they supervised? What's their protections? Does certification matter, and how? What does that build for? What does that show for other kinds of housing? Essential elements I mentioned. How does recovery housing successfully interact with other systems of care? And what are the facilitators to do so? And what are appropriate patient-centered outcomes? What would you want to see as somebody's walking out the door in recovery in a healthy way versus when they came in the door? Next slide, please. And I promise you I'm almost done, May. So a couple challenges. I just want to make sure that we highlight this because recovery housing in particular is different. I already said that addiction care is different, and I think housing, if you think of this as housing and not as clinical care, then it gets very, very complicated. Some models are very defined, and we can use something like the Oxford House for definitions, or we can use something like NAR or ASAM for definitions. But each house may be run differently. Some of that is intentionally, and some of that's just about who lives there. And if you're peer run in particular, or peer managed, where the residents are building the expectations, that may change over time in the same house. Client detail and clients and services may not be consistently collected because this is not really clinical care in most cases. And so you may not be thinking about what kind of data you need. And hand in hand with that, comparison groups are hard to define. And so when we talk as researchers with our research hat on, the methods may be less rigorous and it's harder to find and state with confidence what we found out of the analyses. It's not impossible. So I'm not trying to say don't do it. There's lots of ways that we work around that. Residents may have significant co-occurring issues. That's always a challenge in health services research, is how do you measure? How do you control for those? Residents are part of the milieu. They are part of the intervention, if you call a recovery house an intervention. And therefore, how do you define that? How do you measure that? How do you measure it when they come and go frequently? And what is the intervention itself? Is it just that you have a place to live? Is it that you're in a group with other people? Is it something else? Next slide, please. And I'll just end with a comment on types of data to collect, because this is the one place, if you're engaged in a recovery housing and want to do research, data is the best place to start. And that means getting sociodemographics, doing that consistently, and tracking what kind of services people get. If you walk in, are they going to mutual help? I don't mean that you need to get into all the ins and outs of what you said.
Do you have any extra paper pads?
Somebody to Mute themselves.
Yeah, it looks like she's back up. Counseling, do they get medications? They get legal supports, employment supports that helps get at what is happening. What kind of outcomes are of interest? Is it substance use? Is it employment? Is it something else? Who works in the house? How were they trained? What's the scope of work? And what kind of agencies do you collaborate with? These kinds of things, if you're collecting them, even if you don't have your research question right now, in 6 months from now, you'll be able to start answering what your research question is. So with that, I think I'm going to hop to the thank you slide and pop my email up. I am happy to talk to anybody offline, but Carmen is going to manage some Q&A for us. Thank
Thank
you.
you so much, Dr. Reeve, for that amazing presentation on health services research and where research on recovery housing fits into that research. So at this point, I'm going to give the audience the opportunity to ask questions. We've been collecting questions in the chat as well, and you can continue to drop them there, or you can raise your virtual hands and unmute yourselves and ask questions directly to our presenter. Does anybody have any do we have any questions in the chat, Amy?
We had one, but that was from you, Carmen, about pharmacists expanding access. And I have to say, I want to give a plug for an I-STARR pilot study, which is involving a mobile pharmacy and thinking about how to integrate mobile pharmacies into recovery housing to increase access and adherence to MOUD. So that's super exciting that we're able to support that work.
Mm-hmm. That's great, Emmy. So addressing those major barriers, right? Trying to reduce the barriers to care at every point in the healthcare system. Any questions from the audience?
Yes, I have a question, if I may.
Thank you, Niles.
Yes, Dr. Reeve, thank you so much for your outstanding presentation. I've had many conversations and thought through similar topics before. And one thing keeps coming up for me, and that is, first of all, is there a tension between implementing rigorous health services in the context of recovery residences and the peer-led social support, or sorry, the social model of recovery approach? And if there is a tension between those two approaches, how do we as researchers or as advocates or implementers of health services address those or confront those or attenuate our approaches to accommodate, well, not to accommodate, but to leverage the social model of recovery? And let me be a little bit more specific. I guess I have a personal concern that if I come in with my evaluator hat on and sort of dissemination implementation model or a dissemination implementation science approach, and I think, okay, here's all these things that need to be happening here that aren't already, am I going to be blind to all kinds of things that are happening that are not currently recognized by health services research, or maybe not well understood, or perhaps may not be even supported? And what can I do as a researcher to approach that concern, if that makes sense?
And that is a great question, and there's a lot wrapped up in that, and I will try to answer some. The first thing I will say, I'm going to go backwards, because I think this is a great place for participatory research or community-based participatory research, CBPR, PAR, starting. I mean, in some ways, recovery residences, while they've been around for a long time, in some ways they're still sort of novel. There's a lot we don't know, and the point you're making about what's the secret sauce in the social model. We know a lot about that from mutual help. We know a lot about it from other fields that we can apply. But if you sat down with your recovery residences and said, what do you think the secret sauce is? And how do we figure this out? And how do we define it in a way that if I wanted to say to the guy in the next town over who's ready to open up a residence, look, this is what we think worked. And this is where we have some challenges, and we're being honest about where the challenges are. That's how I would think about it in this kind of, it's not about it has to be medical. It's, even though that's where I started and some of my examples were, it's not that it has to be medical. It's not that it has to be defined health outcomes that are already in somebody's records somewhere and some tracking, but it has to be definable if you want to study it and replicate it. And I think that's where the challenge is, because otherwise what we have is we have a series of case studies and we say, look, housing A, House A is doing awesome work. It's really great. We love what it's up to, but maybe it's doing awesome work because it's getting awesome people in. Maybe it's got a great manager who's got a reputation, is connected in the community, and that brings people in, and then they behave well because they like this guy or woman or whatever. Like you see how you have all these little bits of things that may actually be idiosyncratic. And I think the issue with health services research is we want to get beyond the idiosyncratic to understand how we can build it out and apply it better in ways. So I'm saying don't throw out the social model. I mean, the social model does make it harder, right? Because I mean, this is like talking about clinical research and psychotherapy, right? There's a whole lot that's about the therapeutic alliance. You may say you're doing cognitive behavioral therapy, and this is what I'm doing, and this is how I'm engaging with somebody. But it may be that I like Sarah and Sarah likes me, and we have a great time, and it's all good. But when I talk to Amy, we're just not having the same kind of connection. And I don't think she's understanding my worries in the same way, even though they may both be doing it the same way. So we want to get out of that idiosyncratic piece to what are the big things. And we lose a lot of nuance by doing that. So I want to acknowledge that also. It's a lot harder to see what happens on the ground.
Very well put. Thank you so much.
Sure. Thank you. Great. It was a great question. Yeah.
We have a statement, I think, or question: peer support and having leaders in the home that already have recovery. Now we come back to the definition of recovery.
Right.
From Jen.
Right. Yeah, I think that's absolutely right. And the definition of recovery, I don't think it changes what houses are doing, right? I think there's a lot of on the ground understanding of that. But there's also a lot in the addiction field. Over the years, there's been a lot of, well, this is how I did it, and this is what's going to work for you. And I think we also need to back out of that a little bit and get to how do we really part of it is how do we justify it to funders? How do we get it to the policymakers? How do we get to a community that says, why should we have one of these? Show me it works, rather than showing me you're just housing people who are going to be out, using on the front stoop and messing up my neighborhood. And that's part of the reason to do this also, is to use at these other places.
Do we have other questions from the audience?
I just want to add one quick thing to Niles's question, and Sharon, that was an amazing response. But I just find that the health services research framework is a useful place to start to compare and contrast and discover what may be unique about recovery housing, recovery support services more generally, so that we can use it as a tool to discover what this is and how it works, and how we can answer all these really important health services research questions.
Thank you, Amy.
I mean, I think also, when I get to this idiosyncratic, it may be that the social model, how you engage in it, it's really peer-led and peer-run, and the milieu is what's the most important. But maybe it's also about how many people are in the house. What kind of rent do they pay? Are they expected to be employed within a certain amount of time? Are they allowed to have medications? Are they allowed to get mental health services, or is that stuff forbidden? So it could be that there are a lot of things we still don't know in those kinds of really definable aspects. Even when you're saying, okay, this house is a social model, this house is really level 3 residential clinical care, and those are very different things when we talk about a residential treatment versus a more traditional peer-led house.
Yep,
Right.
and getting back to Jen's question about, or comment about peer support and recovery, that's such an important measure of outcome, of
Yes.
success. It's that's what we're trying to do with recovery support service providers, or recovery, housing providers, making sure that people are in recovery and can stay in their recovery. But what is that?
Yeah. Well, I hate to cut this discussion off, but I think it's time for us to end. I want to give everyone a heads up about some things that are coming up in the next couple of months. So next slide, please. Next month's webinar will feature more I-STAR Advisory Board members, Roland Lamb and David Pading, who will be presenting on Recovery Housing's role in comprehensive community behavioral health services. And in July, we'll hear from another member of the I-STAR Advisory Board. We'll hear from Wen No, who will be presenting on the topic of integrating recovery housing and substance use treatment. The I-STAR webinars, for those of you who are new, are held on the third Tuesday of the month from 11 to 12 for folks on the West Coast, which is 2 to 3 for folks on the East Coast. And you can register for any or all of the webinars that we've scheduled on the I-STAR website. And you can also stay connected through social media accounts, which are listed on this slide. And while you are on the I-STAR website, you also may see information about the I-STAR training series. And the I-STAR training series consists of 12 webinars with separate training topics for recovery housing operators and providers, as well as those interested in conducting research on recovery residences. And those who participate in all 12 webinars in the training series will receive a certificate of completion and will be provided an option of being identified on the I-STAR website as someone who's completed the training. So at this point, because the live training series has ended, we can only track completion of the webinars if you register for the series and view the webinars in the I-STAR learning management system on our website. So if you have any questions about the training series or about how to complete it, please reach out to us. So I want to thank you again. Thank you, Dr. Reif, for an amazing webinar, and everyone in attendance for their time and attention. And we hope to see you back here again on Tuesday, June 17th. Enjoy the rest of your day. Thank you so much.
Thank you. Bye.
Thank you, Sharon. So much appreciated.